by Dr. Suad Abul. She is a consultant pediatric surgeon. She is head of the department and chief of division of pediatric surgery and pediatric urology at Ibn Sina Hospital in Kuwait. Dr. Suad is the first female Kuwaiti pediatric surgeon, graduated from Dublin. She is a general surgery residency at McGill University. She was the first Kuwaiti female to be accepted in the program. Pediatric surgery fellowship at McGill University. She was also the first international doctor to be accepted. She has Canadian board in general surgery and Canadian board in pediatric surgery from Royal College of Surgeons in Canada. She is the president of the Kuwaiti Association of the Pediatric Surgery. The topic today, she has lots of things actually. For the sake of time, we will stop here, and the topic will be presented today by Dr. Suad is undescended testis. What does you need to know? Please, Dr. Suad.
Thank you very much for the nice introduction. Actually, my first slide has actually disappeared for some reason. So I would like to thank the organizing committee for letting me present today. We're going to go very quickly. I think the undescended testis, although it's very common congenital anomaly that we see in the urogenital syndrome in babies, however, we're going to go quickly and run over, touch base on the embryology of the testicular development, just to remind ourselves what's the problem, and then when to refer the patients with undescended testes, and is the hormonal treatment going to be beneficial, and the risk of malignancy, infertility, and then the surgical approach. So as we said, the undescended testes is the common congenital anomaly where the one or both testes actually can be missed or not present or not positioned on the right position where in the scrotum. Can be palpable or non-palpable. Quick definitions about the undescended testis. There are a few definitions that we have to remind ourselves. Undescended testis where it's not there at all, you don't see it in the scrotum. Ectopic where it's actually aberrant course, it doesn't take the normal course of the normal descent of the testis. Retractile where it descended normally into the scrotum, but it has a periodic translocation up in the canal or in the upper scrotum due to the hyperactive cremasteric reflux. During examination, it can be manipulated and pushed down and stay in the scrotum for a few seconds. It can retract again. So examination, during the examination is very important that your hand's going to be warm, relax the kid, give him a nice environment so that he's not scared, so you can distinguish between the undescended testis and the retractile testis. Ascended is actually the pathology that we see when the testis is normally descended, but actually after a few years it becomes ascended again. So this is just to show you where it's going to be, the testis, either if it's ectopic or true undescended testis. It's about 3% of the full-term babies who can present with undescended testes. However, 30% more common, we're going to be in the premature babies. 70% of undescended testes actually can be spontaneously descended normally within the first year of life. This is why we wait until the first year almost to be descended or not. However, I will tell you when to refer these patients to us. The risk factors: IUGR, premature, prenatal asphyxia, toxemia, congenital subluxation of the hip. They say seasonal, it's in the winter more common. Maternal smoking, some hormonal deficiencies, especially the androgen during development of the babies, and of course some congenital association with Prawn-Willi syndrome, gastroschisis, and cloacal extrophy. All these, the pathology, you'll see that because their lack of the intra-abdominal pressure, this is why also it delays the descent of the testes. So when we talk about the embryology, it's a long talk, but if we can just remember ourselves that the germ cells actually migrates into the urogenital ridges around the 7 weeks of gestation, and then it takes it takes the testicular differentiation and the hormonal development at that time. It reached the external genital differentiation by the 15 weeks of gestation. Development of the process vaginalis, where the boy now is developed, this is very important so that it allow and to accommodate the testes in the scrotum. Development of the gubernaculum also is very important, where it keeps the attachment of the testes down into the scrotum. And then there are actually some factors or steps that we want to mention, where there are two steps. The transabdominal stage is controlled by the insulin-like hormone 3, and the and the inguinoscrotal stage, which is controlled mainly by the genitofemoral nerve, directing by the androgen. This is the okay. This is where the diagram, just to show the testes develop in the abdomen near the kidneys, and then as it descends down, it has to have the Mullerian inhibiting substance, where it actually tend to push the testes down into the inguinal region. And then by the insulin-like 3 factors and developing of the gubernaculum, where it keeps it down into the scrotum and fix it down. So why we are concerned about the undescended testes? Because there are two things for a long-term consequences can happen: malignancy and infertility. The risk of the malignancy, actually, it's been unknown. However, they say because the increased temperature, because the testis is not in the normal temperature environment where it can develop, and also because it's in the region of the inguinal region, it doesn't grow very well, it can develop, and these are risk factors for developing cancer. So the life risk for neoplasia in the literature, it's up to 3%. And actually, I was just reading a recent articles, and it says that it can reach to 10%, the risk of malignancies. We were very we're not really focusing on how much is malignancy can be associated, because we don't have enough data for a long-term follow-ups on these patients. However, before we used to say to the parents that we're gonna do the surgery so that in the future we can feel the testes better in the scrotum and we identify and recognize the cancer earlier. However, multiple studies has been shown, and taking biopsies from these testes, that actually the undescended testis has higher risk of developing cancer because of the germ cells are not well developed. So in average, there are fourfolds higher than the average risk factor in the normal population. The risk of infertility. If we see that, if we take unilateral or bilateral undescended testes, and what we can see, if it's untreated, of course, it's higher azoospermia, whereas less sperm count. And if it's surgically treated in the right time, you can actually save the testes from being infertile. When to operate? Before, a long time ago, we used to say that we'll just keep the patient for a few years, 1 or 2 years, and then it will descend by itself. Then the new data now shows that the earlier referral at the age of 6 months is actually beneficial for the babies, because after 6 months, the testes will not be descended normally. So they are less likely to be descended. So to refer the patient to the surgeon, to the pediatric surgeon, it has to be before 1 year, and preferably within the 6 months of age, so that we can actually do the surgery as earlier as possible before 1 year of age to preserve the sperm count and preserve the germ cells. What about the retractile testes? Retractile testes is actually supposed to be a normal testis. However, we know that these retractile testes can be ascended at some point of their life. So 77 of the retractile testes can achieve normal descent. However, in the recent studies, it shows that retractile testis also has some anomalies. If after 7 years and the retractile test is still retractile, it should be fixed, because after that the risk of infertility is higher, and the germ cells count and the germ cells differentiation is going to be low. So how to manage surgically these patients? First of all, any patient comes to us with undescended testes, we have to have a good history of the risk factors, history of kids or siblings that has undescended testes in the family, and also if there is a hypospadias. It's very important to know if there is a hypospadias with undescended testes, so you do a chromosomal study to make sure that the patient doesn't have an intersex disease. So we examine the patient if it's a testis palpable or not palpable, unilateral or bilateral, and what age he's presenting and what's the comorbid conditions. So according to the location and the during examination of these undescended testes, we decide if this patient will undergo primary orchidopexy or first or second, single stage or two stage Faust-Steven. Faust-Steven orchidopexy is where we do it laparoscopically, and this is for undescended testes. What we do is that we clip the vessels, because the testis is in the abdomen, and there is a lack of length of the vessels. So we clip the vessels, and then after 6 months we bring the patient back. We do a peritoneal flap, where we took all the neo vessels that was developed around the testis and bring it down into the scrotum. So just a picture about, or a photo about the how does it look like. The testis, the gubernaculum is here. This is the vessels and this is the vas. Very, very hard to do it at the first stage. So this is why we clip, then develop more blood vessels from the peritoneal cavity and the peritoneal sheet, and then we bring the testis down. So the outcome of the orchidopexies. A lot of studies has been shown why we are doing this. Are we doing harm or better for the kids? And actually, overall success rate for achieving the descent, it's been very good, almost reaching to, I would say, 95 to 100% in the primary orchidopexy. However, in the second stage, because we do it in the two stage, so we have more length of the vessels, we can reach to the descent to up to 86%. The fertility also, it's improved actually. To measure the fertility, we cannot measure it at the infant or childhood life. So unless if the kid get bigger in adulthood and he get married, and then we know that he's fertile. However, there are some indications where you can assess the testicular size and the growth, the testicular histology, and the semen analysis later on, and paternity rate, of course, if he gets married later on. But this is how to assess the fertility. We found that if the patient operated within the first year, the sperm count actually can reach to up to 90%. However, if it's operated after the 1 year, the sperm count and the motility will be less. So 89% of the untreated male with bilateral undescended testes can develop azoospermia, and this is high percentage. How about the testicular atrophy? As a surgeon, we always worry how much we can descend and how is the vessels looks like intraoperatively. We cannot assess that preoperatively. So we always tell the parents the chances that we might not be able to descend and bring the testis completely down into the scrotum. It depends on the tension and the vessel length. This is, I'm saying, in case of the palpable testis that you palpate and you feel it, and then you decide for primary orchidopexy. So the overall testicular atrophy it depends on the surgical technique, the vessels, and the size of the testes during the surgery. And of course, this is like translocation of testes from environment to another environment. So how he can accommodate itself and how can it can develop more new vessels and growth. This is something we have to follow with during the follow-up clinics. So the primary orchidopexy, we can about 1% or 1 to 2% risk of atrophy. One stage Faust-Steven is higher, and because imagining that it's one stage laparoscopically from the intra-abdominal to the scrotum, there is a great tension and you don't have enough length. So this is why most of the time we don't refer to do one stage Faust-Steven. We do two stage because the atrophy is less. So what we need to do, we need to follow the patient first in the first 2 weeks of post-operatively, and then after 6 months of age or 6 months of post-op, and then we follow them until puberty. And this is very important because we have to educate and teach the child how to self-examine himself later on when he's in the puberty time, so that prediction and detection of any tumor or cancers can be early. So, does the hormonal therapy beneficial? It's been used widely before. However, a lot of studies still having some conflict about it. Some studies have most of the studies actually has a limitation factor where there is not enough not enough patients to be studied. They do it on the retractile testes, and the retractile testes showed some improvement if you give the hormonal therapy earlier. And then some of the studies did not give a good dose, or what's the dose that we can use?
1 minute left, please.
Okay. So this is just to mention that one of the studies has been shown that after giving the hormonal therapy for an experimental rat research or study showed that the sperm count actually was very less compared to the first group where they did the surgery right away. Just gonna, okay. So some of the reports actually, or studies has been reported that there are harmful use of this hormonal therapy in patients who actually they don't need it. Virilization effect, which is pubic hair, increased penis size, sorry to say, but erection in the small babies is very painful. Behavior changes, they can be aggressive. These all transient, however, this is severe for a young baby that doesn't need a hormonal therapy. So the most of the time that all these studies has been short, the follow-up is short. We don't have a long-term follow-up for the fertility and the cancer outcome in the patients who have been using the hormonal therapy. So if I just conclude that any boy with undescended testes, please refer them to the pediatric surgeon at the age of 6 months or even before that, so that by the time we examine them at 6 months of age, we will follow them and give them the appointment. So we prefer to do the surgery before 1 year, and the maximum or the beneficial time is actually at 9 months of age. Orchidopexy should be done before 1 year of age. Long-term follow-up is necessary. So if some of these patients, they don't come to us, they come to you for other things, please examine and refer them back to us so that we can examine and get the assessment of the size of the penis. We record the size of the penis, the size of the testicle, and we record the follow-up of these patients routinely. So we need to know how they are doing. And of course, the hormonal therapy, I don't recommend it because it's not been shown great results in the literature. Thank you, and hopefully you did not get to speak.
Thank you very much, Dr. Suad, for a very interesting and elegant presentation. The floor now is open. We may have 2 questions.
Before.
Yes, Dr. Nawal.
Thank you, Dr. Suad. I'm Dr. Nawal Maqsid, metabolic consultant. I see a lot of hypotonia patients for various reasons. And, cryptorchidism is a very common, thing that we see in them. From your experience, do you recommend earlier, referral for those patients? Because whatever is the cause of their hypotonia, whether this is syndromic or muscle dystrophy or, like glycogen storage disorder. So do you recommend earlier referral because the chance that they are gonna descend their testes may be less than, normal running child?
Yes, of course. Thank you for the question, and this is actually very important because we see these patients, and the parents will be a lot like they're concerned. They want the testes to be done because, they want it to be as much as possible normal child. For us, actually, even if you refer them earlier, it depends on the comorbidity of the child. If he has another major comorbidity, we can actually delay because we always counsel the parents and tell them that the chances of having fertility in these patients is very low. And what's the chance that they're going to be, if it's like handicapped or somebody who's really cannot be managed in an adulthood by himself. So we try to do them, but not necessarily at 6 months of age. But we prefer to do them around the 1 year of age because the risk of the malignancy. And when we descend it, it's just because we wanted to make sure that it can be palpated and felt. Most of the parents, they want him to be as normal as possible. However, we know that this child may not be going into the marriage period. So we tell them that it doesn't have to be early repair, but we follow them. As long as they follow and we can feel the testis and we can palpate it, we can, for example, give them an appointment for surgery, but not necessarily as early as possible. We can delay it a little bit, as long as he has no other comorbidities that is active and going on.
We have another question from Dr. Mazen. Please, Dr. Mazen.
Ahlan.
I'm sorry, this is the last question because we don't have time. Please.
Very good question, actually. I did not add this because I didn't want to make a lot of confusion, but since you asked the question, before we used not to do ultrasounds because we said if it's palpable, that's it, go for surgery. If it's non-palpable, the ultrasound actually is not very sensitive. However, now there is a recent study that actually showed that ilioinguinal area testes, if ultrasound is done, it can give you the size of the testes and we can follow it up, and also it can predict that these testes can be descended. However, almost 70%, which I thought it's a large percentage for impalpable testes that can be detected by the ultrasound. So if you do ultrasound and then they found an undescended testis and it's impalpable and it's in the abdomen, there is 60% chance that this testis can be in the abdomen by ultrasound. Did you get what I mean? So the ultrasound, actually, we thought that we don't need it before because if it's palpable, just go for surgery. If it's intra-abdominal, laparoscopy is the main goal. However, nowadays, ultrasound is being shown that it's beneficial even for intra-abdominal because a good percentage of these intra-abdominal testes actually, by the ultrasound, he will tell you that it's actually descended and it's reaching into the groin, what we call it a peeping testis. We think it's in the abdomen, but actually by ultrasound, it's just near the external or the internal canal, so it can be descended.
Okay.
So ultrasound, I would recommend.
Thank you very much. I think we have to move to the third topic. Thank you very much.